Good evening, everyone. I'm Isabel Pedraza. I'm here on behalf of the ATS for our 34th ATS COVID-19 Critical Care Training Forum. Thank you for joining us this evening. A few things to go over before we begin our very interesting topics tonight. Our moderators tonight will be myself. I am from Cedars-Sinai Medical Center, and Dr. Viren Kaul from Cruz Medical. Our presenters tonight will be Dr. Natalie Achamallah, third-year fellow at Cedars-Sinai Medical Center, Dr. Stephen Thomas from SUNY Upstate Medical Center, and Dr. Jennie Lavine from Emory University. I wanted to have upcoming sessions. Episode 35 will happen on September 21st, which is a very timely topic on caring for yourself so you can care for others. How to manage anger, frustration, and sadness in the setting of caring for unvaccinated critical care COVID patients. And episode 36 on October 5th, reviewing COVID in children. There will be sign-up links that are here and that will also be on our website and emailed. All the sessions that we've already done have been archived and recorded and are available for free on the ATS website. And you can find them by simply searching for ATS COVID Forum, or you can scan this QR code. We also would like you to give us feedback on today's session. You can either scan this QR code or it's also available on our website. I'd like to give special thanks to our ATS Critical Care Training Forum chairs, Dr. Laura Crotty-Alexander, Dr. Nira Shah, Dr. Sushma Cribbs, and Dr. Viren Kaul. Also thanks to our team of trainees, Alex Cipro, Carmen McGuire, Ellie Ashgar, Neil Jones, and Mark Rolfson, and of course our ATS staff, without which we could do none of this, Lauren Lynch, Liz Guzman, Eileen Larson, and Allison Curry. I'd like to now turn it over to our first presenter. I'm going to stop sharing. Hold on a second. Okay, I'd like to turn it over to our first presenter, Dr. Natalie Achamallah. Dr. Achamallah did her undergraduate degree at UCLA, where she received a BS in neuroscience, followed by a master's in medical humanities and bioethics at Northwestern University. This was followed by medical school at Royal College of Surgeons in Dublin, Ireland, and a residency at Cottage Hospital in Santa Barbara. She is currently a third-year fellow and one of our chief fellows here at Cedars-Sinai Medical Center in Los Angeles. She has been working with me on quality improvement projects in the ICU and has a special interest in studying the impact of COVID-19 on trainees and career decisions. Welcome, Dr. Achamallah.
All right, thank you. Thank you very much, Dr. Pedraza, and thank you, everybody. As Dr. Pedraza mentioned, I'm going to be talking about two cases, one in a vaccinated patient and one in an unvaccinated patient, both of whom were seen recently in our center, and we'll make some comparisons between the two. So the first patient is an 89-year-old gentleman. He was previously vaccinated. He has history of diabetes and hypertension, as well as monoclonal gammopathy of unknown significance. He has very good functional status prior to his presentation. He developed cough, congestion, myalgias lasting 4 to 5 days. He had a home COVID test that was positive the night before his presentation and was being cared for at home, but developed worsening dyspnea, prompting his presentation. In the ER, his initial SAT was 76% on room air, which improved to the low 90s on a non-rebreather. His respiratory rate was in the low 20s and his vitals were otherwise normal. It was noted on his first exam that he was speaking full sentences, though he did have some difficulty. And they also noted that he had dry mucous membranes, but otherwise nothing of note on his exam. On hospital day 0, he was admitted to the floor on high-flow nasal cannula. He was started on dexamethasone and remdesivir. He was also started on Rocephin and azithromycin for possibility of a superimposed pneumonia. Over the course of hospital day 1, especially towards the evening, he was very delirious and showed significant signs of sundowning, pulling off the high-flow nasal cannula with rapid desaturation every time he did. He required a 1-to-1 sitter and restraints and was ultimately transferred to the ICU for closer monitoring. Unfortunately, on hospital day 2, his work of breathing increased. He was more agitated and his oxygenation worsened, ultimately requiring intubation. And he was also given tocilizumab on that day. This is the chest x-ray from the day of intubation, and we'll return to this later. From hospital's day 3 to 7, he actually had rapidly de-escalating ventilator requirements. He was down to 40% by the day after intubation. He did remain agitated, intermittently having increased O2 requirement related to breath stacking and fighting with the ventilator. He also, over that period, had a brief AKI, which spontaneously resolved. From hospital's day 8 to 10, on hospital day 8, they noted that he had increased secretions and new fevers, also new pressor requirements and increasing FiO2 requirements. So he was started on broad spectrum antibiotics for a presumed superimposed bacterial pneumonia. And after initiation of treatment, his vent requirements again decreased. Over the course of the following week, he was slowly weaned off of sedation, trialed on daily SBTs, but continued to fail SBT. And so discussion was held with family regarding the possibility of requiring a tracheostomy. He was, however, successfully extubated on hospital day 18 and weaned from high flow nasal cannula and transferred to the floor. Thereafter, he required again escalation to high flow nasal cannula, but it was thought more to be related to volume status, and this did improve with diuresis. He is currently working with PT, OT, and SLP, though he remains fairly debilitated. The second case I want to present is a 67-year-old male who was not previously vaccinated. He has history of polycythemia vera on a JAK inhibitor, ruxolitinib, also called Jakafi. He also has history of CAD status post-cabbage a few years prior. He'd had ongoing dyspnea, cough, and fevers times 10 days. He had several positive family members, all of whom were unvaccinated at home, including his wife, who was briefly admitted several days prior for observation and then released. His stat was initially 87% on room air, which improved on simple nasal cannula. He was noted to be breathing into the 30s and 40s, though, and labored appearing with difficulty speaking full sentences. He was also tachycardic to the 120s and hypertensive to the 180s over 100s. On hospital day 0, he was admitted to the floor on high flow nasal cannula. He also was started on dexamethasone and remdesivir. He also was started on Rocephin and azithromycin for the possibility of a superimposed pneumonia. Very early in the morning of hospital day 1, however, a rapid response was called. He was tachypnic into the 40s. His saturations were falling into the 70s despite high flow nasal cannula, and actually with a non-rebreather applied over the high flow nasal cannula while being called for intubation. He was urgently intubated and transferred to the ICU. He was also given tocilizumab on that day, and he was immediately prone and started on a paralytic agent. This is his chest x-ray from the day of intubation, and again, we'll return to this later. Over the course of hospital days 2 to 11, he had some intermittent improvements in oxygenation, was able to stop proning on hospital day 4. He had, over the same period, repeated attempts to hold the paralytic, however, decompensated every time that it was held. It was stopped without restarting on hospital day 7. He also had worsening renal failure and started on CRRT on hospital day 4. He, over the course of hospital days 13 to 15, also noted increased secretions, fevers, pressor requirements, and FiO2 requirement, and he too was started on antibiotics for a suspected superimposed bacterial pneumonia with subsequent improvement. His ventilator weaning was limited by agitation, but he was successfully extubated on hospital day 16. He was then transferred to a simple nasal cannula on hospital day 18 and to the floor on hospital day 19. He was then transitioned to intermittent hemodialysis. He had very significant delirium for the first several days after transferring to the floor and was unable to participate with PT, OT, or SLP, but is currently participating with all 3. He's having ongoing discussion of possible PEG tube and discussion of eventual placement. So just to compare the 2 cases that we spoke about, on the left are 89-year-old gentlemen, and on the right are 67-year-old unvaccinated gentlemen. Both have a history of immunocompromise, in addition to the obvious difference in their ages and functional status. Our 89-year-old gentleman had a history of MGUS, and our 67-year-old gentleman is on a JAK inhibitor for his polycythemia vera. They were both started immediately on dexamethasone, remdesivir, and CAP coverage. Our 89-year-old gentleman was intubated on hospital day 2, primarily related to agitation and work of breathing with subsequent desaturation. Our 67-year-old unvaccinated gentleman had refractory hypoxemia and was intubated on hospital day 1. This is a comparison of some of their inflammatory marker trends. So on the top, these two graphs is a comparison of their C-reactive proteins. If you're looking at the numbers on the side, you'll notice that the one on the right is 10 times higher than the one on the left, but that's related to a difference in units. So actually their initial CRP values were very, very close and downtrended over a similar period of time. Their ferritin levels were also similarly elevated at their presentation in the 1,000 to 1,200 range. And then below, you can see their x-rays on the day of intubation. So not on the day of presentation, but on the day of intubation, and the significant difference in the amount of infiltrates that's noted on the right. To continue the difference in their course, we talked about ventilator requirements rapidly de-escalating for our 89-year-old gentleman, and then extubation mostly limited by mental status, whereas our 67-year-old gentleman had profound hypoxemia requiring paralysis and proning over the course of the first week of his ICU stay. Both courses were unfortunately complicated by ventilator-associated pneumonias. Both had prolonged weaning of their sedation, and both were extubated just after the 2-week mark, hospital day 18 for our 89-year-old gentleman and hospital day 16 for our 67-year-old gentleman. Both are currently undergoing PT, OT, and SLP, and then exploring options post-hospitalization. So some questions that were raised by these two cases, first, what is the efficacy of the current vaccines versus not just the Delta variant, but other variants that are starting to emerge? Would a third dose have impacted the first patient based on his age group and his status as an immunocompromised individual? What is the current data that exists for boosters? And what does the future of our vaccine strategy look like? And with that, I will hand back over to Dr. Pedraza.
All right, so thank you, Dr. Achamallah, appreciate it. So we just saw 2 demonstrative examples of how COVID-19 can progress between vaccinated and unvaccinated patients. With 2 simple cases, it may not seem that different, but we have to keep in mind that one patient was in pretty much an extreme of life, and despite that, did relatively okay. So it's sometimes a small sort of differences with chronic critical care that come into play. So with that, we have our first speaker, Dr. Thomas, who works at SUNY Upstate Medical University in Syracuse, where he's a professor of medicine, microbiology, and immunology. He's also the chief of the Division of Infectious Diseases, Microbiology, and Immunology, and the director for the Institute of Global Health and Translational Sciences. He was one of the main authors on one of the first papers that came out on efficacy and safety of mRNA vaccines, the very first paper actually at NEJM in December of 2020. He has been very closely involved with the development of vaccines. And so he'll be talking about COVID-19 vaccines and how they work against the Delta variant. And then if you have other questions, because I know you've all been reading about the other Greek alphabets, feel free to put them in the chat box. All right, Dr. Thomas, all yours.
Thank you very much. Thank you, the ATS, for inviting me. I really appreciate it. So we're going to go through lots of information. I'm going to break all rules as it relates to how to give presentations, because I'm going to give you lots of information. And I'm going to focus primarily on COVID vaccines, the Delta variant, and I'm not going to focus on safety. That's a whole other 3-4 hour talk. So I'm going to focus primarily just on high level data that we have on efficacy. And I'm going to get that out of the way. So here are my disclosures. I'm a physician scientist, and so I've been working a lot on COVID countermeasures, and as was mentioned, I'm the coordinating principal investigator for the Pfizer-BioNTech trial, but I work with lots of other groups as well. Okay, so we're going to talk a little bit about the virus first, just to kind of level set everybody's understanding. So this is what SARS-CoV-2 looks like. You can imagine it's like a tennis ball with a bunch of push pins in it, but those push pins are actually mobile. They have three different places that they can move, and this is really the business end of the virus, because it is that spike protein which recognizes the receptors on the human cells and different organ systems that we have, and allows that virus to interact with that cell, ultimately get into the cell, release its RNA, make baby viruses, have those viruses break out of the cell, and affect lots of other organ systems. And one of the reasons why COVID has such a very diverse presentation and has such a very diverse clinical phenotype is that we have ACE2 receptors all over throughout our entire body, and in different concentrations in different organ systems. And it seems that different people actually have different concentrations of ACE2 receptors in different organ systems. And so when the spike protein recognizes ACE2 receptors and other receptors on human cells, let's say, for example, it's a lung cell or a cell in our nose or anywhere in our respiratory tract or kidneys or GI system, there are a number of different reactions that will happen. But what eventually happens is that you have the virus on the top and the host cell on the bottom. They get brought together. There's this fusion, and the viral material ultimately gets into the cell. So this is a mechanism that countermeasure developers, whether they're trying to develop prophylaxis or they're trying to develop treatments or they're trying to develop vaccine solutions, this is something that just intuitively you would want to target, because if you can prevent this interaction from occurring, you can either abort the infective process, or you can greatly attenuate the infective process. And this is where a lot of almost all, if not all, vaccine solutions have been targeted. So on the top and the upper left, when you look at that spike protein and you look at people who have survived a natural COVID infection, there's three main areas that we think antibodies bind to try to disrupt that system. There's the RBD, or the receptor binding domain. And if you go around the clock to the left, next you're in the N-terminal domain, or the NTD, and then you keep moving down and in the S2 subunit. And either by mass action, meaning lots and lots of antibodies, or very high quality action, high avidity, high affinity of these antibodies, if you can bind in those different areas, or bind in multiple areas, you can disrupt this process. And what you're seeing below is on the left, you see the genome, the SARS-CoV-2 genome, with the N-terminal domain on the left, and then the RBD, the receptor binding domain. And what you see in red these are the different mutations that are present in the B16172, or the Delta variant. And so just like you need to have a perfect key antibody to fit into a perfect lock, an epitope on the virus, if you disrupt that through a mutation, and those mutations can have lots of different effects. It could even have a structural effect. It could have some kind of positive, negative charge effect. When you disrupt that lock, then the key doesn't fit anymore, and you don't get that interaction that you want. And if you look at the bottom right B, you can see where those different mutations map on that spike protein. You can see where they map in those very key areas that antibodies need to bind to prevent this interaction. And so you can imagine that when these mutations occur, you can understand why natural immunity might be less effective at preventing someone from getting a second infection, or how vaccine-induced immunity, or as we've seen with monoclonal antibodies and these immune therapies, how they might not be effective across all the different variants that we see, because these variants have different types of mutations in different areas. And this was just published today, basically in Nature. And what they've looked at is through in vitro experimentation and kind of looking at different epidemiologic studies. They basically see two different effects that these mutations have. One, for Delta specifically. One, they increase the ability of the virus to attach to cells, replicate, go out, infect more cells, and continue that process. And two, they disrupt the normal innate immune response that would want to try and prevent that process from occurring. So increased replication, efficiency, and immune evasion. Seems to be what we're seeing with the Delta variant, which is why we've seen such a huge change globally in the epidemiology of this pandemic once Delta broke out and started to do its thing. And you can see this, this is just the WHO weekly epidemiologic updates. You can see this is as of 29 August of 2021. And you're looking in the different colors, you're looking at the different regions of the world. You're looking at total number of cases, you're looking at total deaths, and you're looking by the reporting period there. And you can see obviously these surges and valleys that we've seen with on the far right, the most recent surge being due to Delta, with the Americas and Europe making up the majority of what we've seen recently, with Southeast Asia actually showing our greatest decline in the recent weeks. And this just kind of gives you a look at the numbers. And if you go all the way to the bottom globally, so new cases in the last 7 days, 4.4 million. New deaths in the last 7 days, 67,000, and cumulative deaths that we've seen so far during this pandemic, almost 4.5 million people. So lots of human suffering and loss. Okay, so now we're going to talk a little bit about vaccines, but in the pre-Delta period. So I just want to, again, kind of level set everybody's understanding. So this was the first paper that was mentioned that came out. This is the Pfizer vaccine. You're looking at Kaplan-Meier curve. In red, that represents people who received the vaccine. In blue, that represents people who received placebo. And the bottom line up front on this is that greater than or equal to 7 days after dose 2, in follow-up for 2 months, you see a 95% efficacy. And if you look at the insert here, what you see is that there's efficacy even after a single dose. And so those Kaplan-Meier curves start to diverge about 10, 11 days after people get their first dose. And it's a similar picture for the Moderna vaccine. So this was about 93% efficacious in the intention to treat analysis. But again, even after a single dose, so the 2 doses are represented by these arrows, even after a single dose around 10, 11 days, you start to see a divergence of the curve. You start to see efficacy after a single dose, with a very high level, 93% efficacy after 2 weeks after 2 doses. And then the adenovirus vaccines, the J&J vaccine, this was the study endpoints were a little bit different in this trial. They looked at moderate to severe and critical cases of COVID. But the Kaplan-Meier curves, the shapes are very similar. So this was a single dose vaccine. The curves split early after getting vaccinated. They remain split. They remain parallel. They're not coming back together. And so even though efficacy was lower, and I don't show efficacy, the numbers, because it actually differed based upon where in the planet they were, where the clinical trial sites were located, and where different variants were sort of evolving at that time. So it's still highly efficacious against these more severe clinical phenotypes, but little less so than what we saw with the messenger RNA vaccines. So then we, in the Pfizer-BioNTech and both Moderna, started to age de-escalate and started to look at the vaccines in kids. They were not intended to have a clinical endpoint. They were intended to have an immunogenicity endpoint. And so what they saw was in 12 to 15-year-olds, preserved safety, and they saw non-inferior immune responses. When you actually look at both of these trials and you look at the number of COVID infections in vaccinated adolescents versus non-vaccinated, there was only one COVID case in between both trials in vaccine recipients. So very, very high efficacy, but small numbers. So I don't show them because the confidence intervals are pretty wide, too wide for me. And then here, this is something that's in preprint now. It'll be in print by the end of the month. But this is looking at the Pfizer-BioNTech vaccine and looking at data out to 6 months. And so the bottom line on this was preserved safety, but we saw declining efficacy. So if you look at the box that I set up here, we looked at 2-month intervals. So what was efficacy after, 7 days after dose 2 to less than 2 months after dose 2, 96%. 2 months after that, it declines by 6%. 2 months after that, so basically out to that 6-month time point, which more than 50% of the volunteers went out to that greater than 4 months out to 6-month time point. It's down to another 6%, down to 83.7%. So the press got a hold of this and of course said, vaccine's not working, declining efficacy. Every 2 months, it's declining by 6%. But you need to know that the clinical endpoint that was being measured here was any COVID of any severity. So one symptom, even if it was mild, plus a positive test, got a check mark for a positive case. So it may not be necessarily reflective of the clinical phenotype that makes up the public health burden of COVID. So if you look at so that's kind of the baseline vaccine efficacy data that we have for vaccines that are under emergency use authorization or full approval here in the US. And when you look at the hospitalized or fatal cases that are breakthrough cases, so this is based on the denominator here is about 173 million people. And you can see below that for 49 states, about 13,000 people have had reported breakthrough infections. And you can see the breakdown there of what are deaths and what are hospitalized non-fatal and the different demographics that they belong in. So at least by the CDC data and the reporting mechanisms that they have in place, when you're looking at 13,000 as a numerator over 173 million as a denominator, and then you further cut you further slice the pie based on either death or hospitalization, these vaccines continue to look very, very effective at preventing, again, the clinical endpoints that are of greatest relevance or greatest impact to the healthcare system. Okay, so that was all kind of the pre-COVID. So now let's look at COVID, and this was as of today. You see here we're in on the farthest right. We're looking at the Delta peak that we're in. Numbers have started to decline, so about 132,000 cases a day on the daily average as of yesterday, which is a decline. But unfortunately, we just hit our 40 million mark, and in terms of total cases in the U.S., and we're probably approaching more than 650,000 dead in the United States, which I think is pretty close to eclipsing what we saw during the 1918-19 influenza pandemic. So I'm going to kind of like speed dating. I'm going to go very quick through all these different trials and give you the kind of the top line here. So this is from the MMWR, just published last week, and it's looking at frontline healthcare workers. So this is a combination of people who are being routinely tested, as well as people who are being tested because they have some kind of symptoms. And if you look just at the bottom here, you see the pre-Delta variant predominance, and we're looking at unvaccinated versus fully vaccinated, number of participants, total number of person days that are being counted, the number of infections, and then the adjusted vaccine efficacy. And what you see here, and this will be a common thread, you see a decline in vaccine effectiveness between comparing pre-Delta to Delta, in this case going from 91% down to 66%. If you look at nursing home residents, and let's just look up at the top at any messenger RNA vaccine, they were looking at the two that are under EUA, so Pfizer, BioNTech, and Moderna. Again, the aggregate weekly count of residents, so it's a pretty good sample size. We have the pre-Delta, the inter-Delta period, and then Delta, the number of cases, and then the adjusted and unadjusted vaccine effectiveness. Once again, what you see is that efficacy between pre-Delta and Delta goes down. This is looking at a couple of different things. So it's not just looking at single dose, so one dose of Pfizer BioNTech, one dose of Chibadno, one dose of Moderna, but it's looking only at Delta. It's looking at the 18 to 64-year-old age group, and it's looking at CT values less than 30, so implying a greater viral burden, and these are symptomatic infections. And this is represented as an odds ratio. So the closer it is to zero, the greater reduction in risk for that particular endpoint. And what you see, though, is if you just look at the bottom half, which is the primary immunization series that's recommended in the US. So you have 2 doses of BioNTech. This is actually, they gave 2 doses of chimp adeno. And then these are people who had natural infection, but did not get vaccinated. What you see is that vaccines, whether it's messenger RNA or whether it's chimp adeno, they are close to having the same amount of efficacy in the case of messenger RNA, superior to what we would get with natural infection. So to me, this says this idea that I'm going to be fine, I'm young, I'm healthy, no comorbidities, I'm just going to get my natural infection because it's going to be superior to vaccination. That's not necessarily the case. The other thing is, if you look at any positive PCR, anybody with symptoms and anybody that has a high viral burden, the efficacies are all pretty well clustered between the different vaccines. Now, over here on the right, you're looking at the specific difference between alpha and delta, with orange being alpha dominant period, the blue being the delta dominant period. And yeah, what you see across many of these different categories is that the odds ratio is less for the alpha dominant period, or the reduction, the risk reduction that a vaccine imparts to a person in the alpha dominant period is greater than it imparts in the delta dominant period. But statistics matter and confidence intervals matter, and that's why we put them here. It really, I don't think you have, you cannot stand on firm significance in terms of distinguishing the odds ratios, at least in this study in the UK, between alpha and delta. This was in the New England Journal recently, looked at University of California, San Diego Health, and they're looking at their workforce. And basically what they're showing you here is, as we march across the months, from March to April to May to June to July, which basically everything up to June is pre-Delta, July is going into Delta, if not fully into Delta. What you basically see is that there's a pretty consistent efficacy or effectiveness in this real world study from vaccination until we get to Delta, and then it drops. And it drops similarly to what we saw in those previous studies that I showed you. And then this was published a couple of weeks ago. It looks at the Pfizer-BioNTech vaccine and the chimp adeno vaccine, and again, comparing alpha variant versus delta variant and adjusted vaccine effectiveness. And again, what you see is that between the alpha variant predominant period to the delta, the efficacy goes down for both these vaccines. But again, the efficacy is not declining. It's not declining significantly. And then this is just another table from that same paper, showing the difference between getting partially vaccinated versus fully vaccinated. Again, the difference between alpha and delta is narrow once you get the full immunization series that is recommended. Just kind of closing it out, a couple of slides from the ACIP meeting that went on last week, where they looked at this. So this is taking a couple of different studies in different groups. So healthcare workers in green, nursing home residents in blue, specific vaccines, purple is Pfizer and yellow is Moderna. And this is vaccine effectiveness over time between the pre-Delta period and the Delta period, which you can see here is in July, against infection, right? So as a vaccine developer, I can tell you, we don't typically make vaccines with the intent that we're going to be able to prevent infection. That's a very high bar. If we can do it, that's great. What we're really trying to do is to impact clinically meaningful, clinically relevant disease. Relevance defined by in a public health perspective, in a public health context. So what we are seeing here is that when we get into Delta, no question, the effectiveness against preventing infection has dropped, and in some cases it has dropped precipitously. But when you look at hospitalization, it's pretty preserved, right? We're looking at anywhere from mid to high 90s mid to 97, 99%, down to even at the lowest. So this one Paranik et al. Study in purple here, above 70s. And we all know the context, right? The context is influenza, which is 45 to 50% in a particular year, and has a huge both direct and indirect public health benefit. When you look at the pre-Delta and the Delta periods, and this is across all sorts of different countries, it includes the UK and Israel and the US. Yes, when you're looking at infection or any disease of any severity, pretty significant drops between effectiveness of vaccines against pre-Delta and Delta. But when you focus on those severe clinical phenotypes, the phenotypes that are going to fill up your outpatient clinics, emergency departments, and hospitals, the drop is not as significant as it's made out to be. And these are just looking at specific studies from specific parts of the world, comparing alpha in blue to delta in orange against different clinical endpoints, either infection, symptomatic infection, hospitalization, or severe disease. The point, again, being that if you're going to look at infection or you're going to look at clinically mild disease, yes, there's absolutely a difference in the effectiveness of these vaccines to prevent those endpoints. But if you're looking at severe disease, hospitalization, death, they've maintained their effectiveness. And this is just another way to look at the same kind of information in a different way, with the blue dots looking at the Pfizer BioNTech vaccine, green dots represent Moderna, red dots represent either, and the yellow dot represents any of the vaccines. And again, to me, what's most important is focusing on these clinical phenotypes to the right. And pre-Delta, post-Delta, we've maintained efficacy against those. So in my opinion, these Delta mutations support infectivity, and they support evasion of the innate immune response, which results in increased transmissibility and more severe illness. I think there's more and more data that's coming out that hospitalization rates and severity of the phenotype are worse with a Delta. And the potential for vaccine-induced immune escape is it's possible. So they've done lots of studies looking at neutralizing antibodies in vitro, and the ability of vaccine-induced neutralizing antibodies to neutralize different variants of concern or interest is variable for sure, which then puts forth the possibility that there could be breakthrough, and I mean breakthrough in the very largest sense. But in vaccines in the time of Delta, they're definitely less effective at preventing infection. They're probably less effective at preventing mild clinical phenotypes, but they seem to be maintaining the effectiveness at lowering the occurrence of severe phenotypes and critical phenotypes and death, which I think is at the heart of a lot of the debate that's going on right now between regulatory agencies, scientists, physicians, and the White House. So I'm going to thank you for your time, and I'm going to stop sharing and turn it back over to our host.
Thank you, Dr. Thomas. That was a wonderful talk. There aren't any questions yet that I can see in the chat, but I had one question. I see a lot of patients. We have a COVID recovery program, and so I see a lot of patients there that are questioning whether or not they need the vaccine or not. And patients in my regular clinic that ask me about, the efficacy of these vaccines. I guess what's the take-home message when talking to these groups? Is it that, it may not be perfect in terms of preventing disease itself, but, there's efficacy apparently in preventing severe disease?
Yeah, I think the take-home point is that they have received lots of vaccines in their life that are not perfect, that wane over time. And I did a little exercise of digging into declining efficacy of different vaccines that are already as part of our immunization schedule, and a lot of them track what we're seeing actually with these COVID vaccines. So I think that's the first, is to tell them this is not a new concept. Second is that, will it prevent them from getting infected? It may, more than not getting vaccinated. Will it prevent them from getting, what may feel like a head cold or a sinus infection? It may. But really what's important is it's going to keep them out of the hospital, and it's going to keep them from dying. It's going to reduce their ability to transmit it to one of their higher risk family members or unvaccinated people in the home, to include children. And then the other thing, which I didn't even mention, but that is also becoming to light, is that it's going to reduce the risk of long hauler syndrome significantly, which we know up to 30% of people who get COVID experience that, and that goes on for months and months in some cases. So, and then what we didn't talk about, but I can tell you the safety profiles have been preserved. They're really excellent. They're consistent with other vaccines, and the risk benefit is clearly on the benefit side. So I think those are the take home points.
Thank you so much. I'm going to invite you to answer a couple of questions chat box. So Dr. Thomas will be answering those. In the interest of time, I want to move on to Dr. Lavine. Let me just, so Dr. Lavine. So I'm very excited about this because Dr. Lavine, I first came across her in the ZDogMD podcast. Those of you who are familiar with ZDogMD, where he was talking about a great article. Let me see if I've posted it in the chat yet, where she talks about how this becomes endemic and the mechanisms behind how that occurs. Dr. Lavine is a computational biologist with extensive experience developing mathematical models and fitting statistical models to data. She is an academic research scientist at Emory University. She did her undergraduate at Emory University, where she received a bachelor's in biology. This was followed by a PhD in biology with a focus on epidemiology at Penn State University. She's been spending the past year doing COVID-19 endgames via epidemiological and immunological data analysis and modeling, something that sounds incredibly complicated and very impressive. So I'm very excited to introduce Dr. Lavine.
Thank you guys so much for having me. Can you see my screen share right now?
Yes, we can see it.
Okay, fantastic. Yeah, thank you for having me, and really a huge thank you to everybody who's on the front lines, because as much as I am thinking about all of this and looking at the data, the truth is I'm sitting mostly in the comfort of my own room. So a huge thank you to everybody who's out there and risking your life on this. It has been quite a year for people who study infectious diseases in terms of trying to understand how something, a virgin epidemic, turns into whatever it might turn into. So back about a year ago, I and two colleagues started thinking about what might happen with SARS-CoV-2 and whether it was likely that we would eradicate it, or whether it was more likely it would become endemic, and how mild or severe it might look in the endemic state. So we started this project over a year ago. And this paper was published back in January. And of course, since then, we've seen many things unfold. So I'm going to sort of walk you through the general idea of why we predicted that it would become endemic, that SARS-CoV-2 would become endemic, meaning it wouldn't go away. We couldn't eradicate it, not even locally. But that the future was relatively optimistic in that it was likely to become mild once everybody had gotten sort of their first round of infections or vaccinations. So sometime out in the future, a few years from now, it would be likely to be mild. And then very specifically, what are the key things that determine whether or not it will be mild? And what does the data that we've seen in the past 6 months tell us about, yeah, okay, is it really gonna be mild? So I guess the first piece is that it seems like it's endemic. It's not going away. I think almost everybody agrees with that now. The chances of eradicating it are slim to none. And this fits very well with what Dr. Thomas was saying about, we don't expect vaccines to necessarily prevent all transmission and infection, but they do really reduce disease. but is it going to be mild in the long term? And how does that relate to booster doses and the future of vaccination against COVID-19? So with that, this paper that we presented predicts a mild endemic future for COVID-19. And the basic idea of this is that, these are model simulations from an age structured model. And what you get, regardless of the three different plots here you see at the top is slow transmission, and at the bottom is very rapid transmission. And in any of these scenarios, you get some kind of initial peak. So the black line, goes up sort of near the left side of the plot and then comes down but never goes away. So it's followed by lower incidence during an endemic period. Initially, all age groups are getting primary infection. So the age groups here are represented by the different colors. This salmon color is kids 0 to 10 years old. And then all the way down, it goes increasing age groups until you get all the way to the bottom. And this magenta is over the age of 80. So initially, you can see the whole rainbow. Everybody across the spectrum is getting a primary infection and getting whatever kind of disease happens after primary infection in that age group. But as time goes by, primary infections are more and more happening in young children. And this is because everybody, and so the more quickly people get exposed, whether by infection or preferably by vaccination, the quicker we get to this place where primary infections are pretty much just happening in young children who have not had a first exposure. And as I didn't put this figure here, and I probably should have, but I suspect that everybody in this room is definitely aware of the very strong relationship between age and the severity of disease for COVID-19. So when 0 to 10-year-olds are getting a primary infection, even now, on average, the disease is very mild, on average, not in every single case. In contrast, the disease severity as measured, for example, by the infection fatality ratio is much, much higher and seems to, in the US, increase pretty much exponentially with age. So these cases, when you get out to this endemic phase and the only primary infections are happening in young children, those infections also tend to be mild. Exactly how mild is something that we're starting to get a grip on, but it'll probably take us longer to really know that, but certainly nothing like the kind of severe disease that we're seeing overall at the moment when we're looking across the board of age groups. As I mentioned before, this transition to this endemic state and what this model predicts a mild endemic state is more rapid when you have extremely high exposure. So this is a very fast transmitting pathogen, but the same prediction for how long it would take to get to this mild endemic state would be for rapid mass vaccination. And of course, this vertical looking black line is actually a huge peak, right? And so this says in this initial phase, if you let the virus sweep through, it would relatively quickly get to an endemic and possibly mild state, but this would be absolutely devastating. So we're not even seeing things like this here in the US. We're always seeing R0s or transmission rates that are modulated, sometimes significantly higher than one, but often becoming much lower, becoming lower than that also, as we see, transmission chains breaking as we're using more transmission blocking measures. One of the predictions of this model is that pretty much everyone alive today will get infected. Whether or not you get vaccinated, you'll get infected, 10 years by 10 years from now or something. So if we can get to this place with vaccination, to this mild endemic state or to this endemic state with vaccination, it doesn't mean that people aren't going to get reinfections, just as Dr. Thomas was saying, The real question is, how severe are those breakthrough infections or reinfections going to be? And Dr. Thomas just gave us a wonderful introduction or amazing look at the current data on what we know about how severe those breakthrough and reinfections are. And he really made the point, yes, we are seeing some degree of breakthrough infections. Yes, the vaccine isn't perfectly effective at preventing infection, but it does quite consistently drastically reduce disease, even in the people who get those breakthrough infections. So the basis of our model was actually thinking about this very question: what happens when you get an infection and immunity starts to wane? And we're really focusing on these sort of two different aspects of immunity. So there's transmission reduction, which we call immune efficacy with regard to susceptibility and infectivity. And then there's disease reduction, which is immune efficacy with regard to pathology. So you might imagine that a primary infection or vaccination gets you to some place on this level of immunity. So that's this kind of white to brown line is showing how much immunity you have. And the blue arrow is, this top blue arrow on waning immunity is showing with time that amount of immunity decreases. That could be measured by neutralizing antibody titers. It could be measured by other antibody titers. It could be measured by specific T cell populations. And it can also be measured functionally. So the primary infection or vaccination gets us to some point in this spectrum. And then at some point, your immunity starts to wane and you lose this really strong sterilizing immunity that prevents infection, if you ever had it. Maybe you had it, maybe you didn't. But if you did, it seems to wane with time. And this is a fairly common, this is not specific to SARS-CoV-2. This model is actually based on the endemic coronaviruses. So this phenomenon is seen with the endemic coronaviruses. It's also seen with influenza, for example, and many, many other things. Immunity wanes with time. Another possibility, and what we're frequently seeing now, is that immunity starts to wane and the reinfection happens with a new variant. So we now have the question of how severe is reinfection or a breakthrough infection, and then how severe is that breakthrough infection if it's with a different variant. What we really want to know is how many exposures and what types of exposures does it take to get strong, meaning a high level, and broad, meaning across different variants, disease-reducing immunity. So again, I'm coming back to what Dr. Thomas was saying, this focus on disease reduction rather than like limiting severe disease rather than limiting virus transmission. And we want to think about a couple of these. So I'm going to put 3 of these questions here and then look at a couple of scenarios real quick with you about how these things might interact. So how fast does disease-reducing immunity wane? How quickly are new variants emerging? And how does the patient's age interact with all of this? So first, I want to think about this idea. How do we generate strong, broad, disease-reducing immunity? In the most optimistic scenario, one exposure to any variant provides long-lasting disease-reducing immunity. The reality check for this, and Dr. Thomas just presented lots of evidence along this, is that breakthrough infections with Delta are much milder than primary infections. And I would say on average, they're still a bit more severe. Even the breakthrough infections are a bit more severe than, for example, seasonal influenza. So we're still looking at some kind of disease that we're not really super happy to be seeing in the population, but the vaccines are certainly working in that they're drastically reducing disease severity. And we might hope that with time and breadth of, with more exposures and more varied exposures, we will indeed get to a place where this really does become mild. What are the implications of this for booster doses? Well, in the short term, which is sort of now, while the virus is in this phase of rapid evolutionary change. A virus just came into a whole new environment of the human population, and it's rapidly exploring that environment. It's how can it be most fit? How can it be most transmissible in that environment? It's changing rapidly. And while it's changing rapidly, it seems reasonable to think that at some point, it's maybe not urgent because the vaccine is working quite well at reducing disease, but one might imagine that an updated vaccine targeted toward currently circulating variants could indeed reduce disease burden. In the longer term, it's actually unclear whether that will even be necessary if the virus continues to evolve rapidly, antigenically rapidly, sort of similar to influenza A, for example. Regular booster doses might also be useful, but only, time and future studies will tell us that. The other question I wanted to delve into a little bit is what is the impact of age? So the age that you are now, the age that you are on this primary infection, how does that influence the immunity that's generated and your response to the vaccines? So in the most optimistic scenario, an adaptive immune response generated by vaccination or natural infection is both as broad and long-lasting in older people and those with compromised immune systems as it is in the population at large. That's probably not true. Certainly the compromised immune systems, we know a lot about that. The age, we're looking at this. So some immunologists are studying how the age of primary infection currently with SARS-CoV-2 affects the immune response. And there are patterns that suggest that breakthrough infections with severe disease may be the vaccine is less effective in older people than younger people, which could relate to the aging of the immune system. It's not totally clear though. Recent data, so some things suggest that, other things seem to suggest that age is actually not a huge predictor of vaccine efficacy. It is obviously a predictor, a huge a correlate of disease severity, regardless of whether you're vaccinated, but does it affect vaccine efficacy or not? That's a question mark. Again, an implication for the booster doses, if immunity is not as protective in at-risk populations, or we could phrase that in populations in which the vaccine is not as effective, booster doses are likely to be useful for those subpopulations. So just a kind of summary of where this, if I were to kind of take all of this information and what can we strongly say, well, immunization of at-risk populations will always be useful. And this is similar to what we say for flu vaccines. So we typically think that vaccinating young infants is useful because they have a somewhat higher risk of disease. And then certainly vaccinating the elderly is useful. Once we've entered a steady state in the demographics of infection, meaning when I showed you that picture with all the rainbow colors, that was showing that right now, the ages of primary infection mirror the age distribution of the population, and that will completely change in the future. So once we've entered that steady state, vaccination may not be necessary at all. That would be the optimistic version. However, two, I think, really important things to consider. Similarly to influenza, immunization in babies may be optimal so that people's first exposure is via vaccine rather than infection. Again, I think we're going to have to keep monitoring over the next number of years how severe COVID-19 is in young children, whether it's really necessary to vaccinate all young children. It certainly may be optimal. So I think that's something that we get to see as time goes by. And then similarly, I think that so that's one question, should we be immunizing children in the long term? And the second is, should we be getting these kind of regular booster doses in the long run? And I think the answer to that is going to depend on the rate of antigenic evolution. So if it is falling into the flu A category of how fast it's changing antigenically, then likely we would want to have regular updated booster vaccines. And if it's not, if it's more like the other endemic coronaviruses, which do undergo antigenic evolution, but more slowly, we may not need to have those regular booster doses in the population at large. And with that, I'm going to say thank you guys so much for listening and for providing this opportunity for people to share and learn. And if we have time for any questions, I would be more than happy to answer some.
Thank you, Dr. Lavine. Thank you, Dr. Thomas. And Dr. Pedraza is going to be coming on. So Dr. Thomas has been taking some of the questions in the Q&A. So maybe we'll just ask the ones that are yet to be addressed. Do you want to go for one? Do you have Dr. Pedraza, or should I start?
I think she addressed all the questions that I had. I think that your article was sort of the first glimmer of hope that I've had in this pandemic. I suppose, and I think you addressed this in one of your first slides. How do you see this playing out in terms of how, if everything works as it should and everybody gets vaccinated, how long will this process take? And will there still be people who are at grave risk? How long do you see it until this process actually becomes endemic?
Yeah, so I think reaching that mild endemic state, the most optimistic, in my view, would be, let's say, this coming like a year from now or so, which would mean one more season of high transmission and more people getting vaccinated. So one more respiratory virus season. That's the most optimistic scenario. I think we're obviously in a bad place right now, and I think given that respiratory virus transmission goes up in general in the winter in the US, it's likely that this coming season is going to be pretty rough. And this gets to those things that I was sort of mentioning in the presentation, if that kind of first exposure, either through vaccination or a natural infection between the start of the pandemic and let's say a year from now, is enough to provide long-lasting, broad disease-reducing immunity, we could be at a mild endemic state then. I also think it's perfectly plausible that there'll be a few more variants that come through that evade immunity enough, even if that's not the strongest selective pressure on them, just as the virus is adapting to transmit better in humans, because that is sort of what viruses do, right? Their selective pressure is on transmission primarily. And as that happens, different parts of them change so that they accomplish that. And our immune system doesn't automatically get updated to, SARS-CoV-2 3.0 or whatever we're at. So I could imagine it taking a few more years. And then I think the other questions remain, like, is it going to be worse than that? I'm still fairly optimistic that within a few years it will be fairly mild, but time will tell.
I have one more question. I know that boosters right now are recommended until we get further data on that basically you get boosted with the same vaccine with which you were vaccinated initially. There have been a couple of papers published on cross-vaccination with other vaccines. Do you see this being more of a benefit? Should we be looking at doing vaccination? This is to both you and Dr. Thomas. Should we be looking more at doing vaccinations with other available vaccines other than the one people received?
Yeah, this is Stephen. So what has currently been authorized is a third dose as part of the primary immunization series for those folks that are highly immunosuppressed. The booster dose, so people who respond appropriately to the primary immunization series, but they want to give a booster dose to try and increase the duration of protective immunity. That's still very much in being discussed and in play. And I'm not really sure, I wrote a little something in the chat there, I'm not really sure how the ACIP and I'm assuming the FDA is going to having seen the data, I'm assuming the FDA is going to look at the data and say, yes, it is safe, and yes, it does what it's supposed to do, because you're seeing these huge 5 to 11-fold increases in neutralizing antibodies across different populations, and that's a good thing. But how it's going to actually be employed, which is the ACIP's job, I am not sure what they are going to say. They've tipped their hand a little bit in the meeting that they had last week, and I think that they might follow the same game plan that they did for the primary immunization series, which, people in long-term care facilities, people over 65, people who are, have medical comorbidities, first responders, I think that makes sense. But I think the window is also going to be open for, especially since the vaccine can now be marketed because it has a licensing authorization, it has a full approval. It's going to be made available eventually to medical providers to use it in consultation with their patients. And if it's an off-label thing, then it's an off-label thing. They're gonna do that. In terms of heterologous prime boost, I mean, there's lots of different. We've looked at that for lots and lots of vaccine nuts that have been hard to crack. We've looked at it for dengue, we've looked at it for malaria, we've looked at it for flu, we've looked at it. I mean, I think it's the basis for Sputnik in a way, right? It's 2 different adenovirus vectors, and I guess the question is always, in a way, from a scientific perspective, I think it comes down to, from the safety is going to be related to the safety of the individual vaccines. I don't think the idea of enhanced disease, this concept that was originally being touted because of what they saw in animal studies with SARS-CoV-1 and MERS-CoV candidate vaccines. I don't think that's really going to be. I don't think we've really seen any evidence that that's in play. So I think that the safety is going to be related to the individual vaccine components and the immunogenicity. It seems like in the studies that they have done is pretty good. I don't think it's going to come down to science. I think it comes down to actually practicality of how you package all of that up. And as a vaccine provider, are you really going to be storing more than one vaccine? Are you really going to be trying to get your logistics in place so that you can store products at very different temperatures? And how are you going to keep track of who got what? I think what we're going to run into is what has been in the chat, which is, I got J&J. There's nothing available that tells me what to do with booster doses for J&J. I'm going to go outside my vaccine class because I'm somebody at high risk of getting infected, or I'm at high risk of a bad outcome if I do get infected and I live in a hot spot. I think that that's probably going to be the case. Or I got Moderna, I'm in line, it's my turn, there's no Moderna available, I'm just going to stay in the same vaccine class and get another mRNA, vaccine. So I think it's going to be less science and more practicality and timing than anything.
Dr. Thomas, Dr. Pedraza, here, I was going to actually say this later, but talking about practicality, right? So here's some important stuff about mixing vaccines. So you all know Israel started giving 3rd dose of Pfizer vaccine, right? So they didn't mix, and they've delivered already, I believe more than 1 million doses of boosters. So here's what Turkey is doing. So starting July, they started giving boosters to healthcare workers and people over 50, right? So they initially gave Sinovac and Pfizer, and then they realized that a lot of countries were not recognizing the Chinese Sinovac. So they were like, okay, if you want to travel, you can go ahead and use Pfizer for the booster. So talking about practicality, I'm talking about, and I know today's a scientific session, but I'm going to tell you what other countries are doing. Uruguay, which started with Sinovac, then said, never mind, Pfizer's fine. And then Cambodia and Thailand said, you know what, everybody's doing whatever they want, so you can go ahead and mix AstraZeneca in there too. So I'm sure that another 4 or 5 months, we will have country level studies at least. They might not be controlled, but they'll be there. Maybe we'll close out with this question. I think this is a very important question. And so both of you, Dr. Lavine, if you want to go first, or Dr. Thomas. is there clinical outcomes data that booster doses work, or is it just antibody-based data?
Dr. Lavine, do you want to go, or
I
know
haven't,
one.
no, I haven't seen a lot of specific data on it, so go for it.
Yeah, no, I think Israel.
Yeah.
Israel is starting to, because again, they went back to the front of the line. They went back to the most vulnerable populations. They started boosting them. And what they saw was a dramatic decline. Yeah, so Delta comes through. They're seeing a certain demographic, older people with comorbidities, who start making up, again, the larger proportion of people getting admitted to the hospital and having bad outcomes. They then institute a booster program, and that population then starts to decline in terms of the percent that it is contributing to clinical cases. So that's been in the lay press. I think there's a preprint out there, but that's really the only thing that I've seen. But it's interesting. You mentioned, that Israel's given over 1 million booster doses. The United States has given well over 1 million third doses already as well, but we haven't heard any. We're so big, we haven't really heard anything about it.
Yep. So 9 million booster doses worldwide, guys. I'll leave you with that. And there's that article.
I wanted to ask one more. Sorry, Viren. There was, I heard it was last, a report on Moderna causing double the antibody titer of Pfizer. And so there's a question in the chat about, does the dose of the neutralizing antibody correlate with antiviral T cell activity? And it also says, should the third dose be recommended to individuals with low level of activity? So, does the titer correlate with ability to neutralize? And should I be worried that I got the Pfizer and not Moderna?
Yeah, well, they're both messenger RNA vaccines, but Moderna delivers 100 micrograms per dose, and Pfizer delivers 30 micrograms per dose. So you're getting almost 3 times the number of spike protein copies per dose. We also think that the reactogenicity that people experience is related to the RNA component, which is probably why the Pfizer vaccine, the Moderna vaccine is a little more reactogenic than the Pfizer vaccine. There are some subtle differences in the lipid nanoparticle, but I think it's the message. I think it is a dose effect as it relates to neutralizing antibodies. It's also probably why, Moderna is reporting antibody persistence data, which is probably going to be superior when we look at other messenger RNA vaccines, because they're just giving a huge dose. But this is one of, and I'm not giving you inside baseball. I've read this in the newspaper. This is one reason why Moderna is not ready to go with the FDA. Is they are saying, this is what I've read, that they need more data on the new dose that they are proposing for their booster, because they're proposing a 50 microgram dose for their booster. So that's a little bit of a mix and match within a vaccine. How it all relates to T cells, I have no clue. And I've always looked at, I'm a recovering dengue guy, and so where antibodies are the bane of our existence. To me, I always look at it as, you can have low quality antibodies, but if you have a ton of them and you have a lot of open epitopes, you have the potential to neutralize the virus. If you have a low titer but very high quality antibodies, all you got to do is get into that right, fit into the right epitope that's going to completely disrupt that process, the cartoon that I showed. So I'm not sure. I don't really know yet.
I'll just add to that. So Sheen Crotty's group has done some really nice work on the T cell responses to the vaccines. And the T cells tend to have a somewhat broader set of epitopes or a somewhat different set of epitopes for antibodies that they bind to. And so I was actually wondering whether, just having spike protein was going to really reduce the T cell response. The data so far seems to suggest that the vaccines induce the mRNA vaccines induce a robust T cell response as well, which is very optimistic.
All right, you both made me feel a lot better about my Pfizer vaccine.
All right, guys. So with that, we're going to close out. Dr. Achamallah, Dr. Lavine, Dr. Thomas, thank you so much. On the side note, Dr. Crotty, Shane Crotty, did come on ATSC CTF. So I believe it was the 8th episode or 7th episode. So check that out. He did talk about the T cell responses. And if you want us to cover any other topics, just leave us in the feedback on that QR code. And with that, we'll let you go. Sorry, we're 15 minutes behind, but thank you so much, guys.
Thank you, everyone.
Thank you.
Thank
Bye-bye.
you, Dr. Lavine and Dr. Achamallah.